Hello, my name is Dr. Kevin Richardson. I'm presenting this case report with Dr. Enrique Benavides III, becoming an airhead while pregnant, pneumocephalus and seizure in pregnancy following epidural anesthesia. This is the case report. The following slides will have much more detailed information. Please stop the presentation at your leisure to read the slides, as the information provided in the slides should answer many questions that may arise. Pneumocephalus is a rare complication of epidural anesthesia that can produce seizures in the peripartum period. Identifying the cause of seizures in the peripartum period is vital to ensure proper management of the patient. Our patient was a 29-year-old female without a seizure history that presented to labor and delivery and her 39th week of pregnancy and active labor. As she progressed in her labor, she requested an epidural anesthesia that required multiple attempts to achieve. 5 hours after her epidural was placed, she had seizure-like activity that required emergency C-section due to fetal heart decelerations. Operatively, she was given endotracheal anesthesia, including ketamine. In the post-op period, she did have a head CT that identified pneumocephalus, which will be ruled as the primary cause for her seizure. She was given magnesium and lorazepam for possible other causes of her altered mentation. There have been other reported cases of seizures and pneumocephalus in the peripartum period. Most, if not all of them, have been in the postpartum period. Pneumocephalus with seizure is a very rare complication of a very common procedure performed in labor and delivery, which is why it should be considered in the differential diagnosis for all seizures after an epidural has been placed in labor and delivery. Epidural anesthesia, like everything in medicine, has risks and benefits to it. It is not a benign procedure. There's a very well-known complication for epidural anesthesia to include maternal hypotension, a high block or total spinal anesthesia, toxicity, and post-dural headaches, and then not achieving the desired amount of anesthesia. Rare complications are epidural abscess, meningitis, and neurological complications like seizures. The pneumocephalus occurred from the loss of resistance with air technique that was used to place the epidural anesthesia. Most patients with pneumocephalus are asymptomatic or have very minor symptoms. The more serious presentations of pneumocephalus are intracranial hemorrhage and altered mental status. Treatment of the pneumocephalus is usually conservative with observation, but you can give oxygen to help with the reabsorption and analgesia for pain control. If you believe there is infection, please give antibiotics. The patient was a 29-year-old premagravid female with an uneventful prenatal course. She presented to labor and delivery in her 39th week in active labor. As her labor progressed, she requested an epidural that required multiple attempts to achieve. 5 hours after placing the epidural anesthesia, she had an amniotomy. She did complain of headaches prior to the amniotomy. Shortly after the amniotomy was completed, she had a seizure-like activity of flaccid muscle tone with bilateral horizontal nystagmus. This lasted for over 10 minutes. For 5 minutes, she was in a postictal period and then had a second seizure-like activity with fetal heart decelerations. This prompted the emergency C-section. During this entire period, her vital signs remained stable. She was normal tensive with good oxygen saturation. In the OR, she was given general anesthesia and ketamine. Baby was born without incident. In the post-op period, she had a head CT that demonstrated pneumocephalus in the lateral horns. She was given magnesium and lorazepam for other possible causes of seizures in the peripartum period. After the cesarean section, she complained of global headaches and generalized arthralgias. She was discharged 48 hours after delivery. She was seen in clinic later on, and her symptoms had resolved. Eclampsia was at the top of the differential diagnosis but was quickly moved down the list due to clinical presentation. Her only risk factor for an eclamptic seizure was headache, which is not pathognomonic. Her seizure activity was also not fitting with the classic eclamptic seizures of tonic-clonic and lasting 60 to 90 seconds. She could have had a new onset seizure disorder, but this is diagnosed based on exclusion. Postoperatively, she had a head CT which demonstrated pneumocephalus. Neurology speculated that she had a seizure due to overpressurization from the pneumocephalus, which became the most likely cause of her seizure activity. Pneumocephalus should be included in the differential diagnosis of all seizure activity following epidural anesthesia in patients, because this is a very rare complication of a very common procedure in labor and delivery. These are enlarged images of her head CT showing pneumocephalus in the anterior and lateral horns. These images show the pneumocephalus in the subarachnoid space posterior to the sella turcica. This concludes the case presentation. Thank you for your time.